Hello friends, welcome back. So today I promised you to show the Kurzman spirals. So this is F is the Kurzman spirals and G is for the Charcot latent crystals. Okay, the eosinophilic hexagonal crystals. This thing is Charcot latent crystals. Okay, now let us begin the bronchiectasis. Bronchiectasis, the finding will have a purulent sputum, recurrent infection, hemoptysis, and digital clubbing. This is very important. Okay, digital clubbing, and there can also be hemoptysis. Remember that. Um, Pathology: chronic necrotizing infection of bronchi or obstruction, permanently dilated airways. Okay, so there can be chronic necrotizing infection of bronchi or obstruction which will lead to the permanently dilated airways. It is associated with bronchial obstruction, poor ciliary motility, example smoking, Cartesian syndrome, cystic fibrosis, allergic bronchopulmonary aspergillosis, and it is also associated with secondary amyloidosis. Okay, now talking about the restrictive lung disease. Restrictive lung expansion causes decrease in lung volume. There will be decreased FVC and total lung capacity. PFT, increase FEV1 by FVC ratio. Patient present with short shallow breaths, also in anxiety, and this you can see short and shallow breath also in anxiety. Okay, but it is rapid. Okay, so how to remember this? Whenever you have a case of fibrosis, think of frequent breathing. F for fibrosis and F for frequent breathing. Okay, now talking about what are the different types. So one type is normal DLCO type. Okay, with normal AE gradient, and there can be decreased DLCO type with increased AA gradient. So poor breathing mechanics, extrapulmonary. Okay, so anything outside the pulmonary is called normal DLCO or normal AA type. For example, poor muscular breath effort, for example in polio, myasthenia gravis, and GBS, right? And poor structural apparatus, for example scoliosis or morbid obesity. Interstitial lung disease, pulmonary, decrease in DLCO, increase in AA gradient, pneumoconiosis, co-worker pneumoconiosis, silicosis, asbestosis. Sarcoidosis, bilateral hilar lymphadenopathy, non-caseating granuloma, increase in ACE and calcium, right? Idiopathic pulmonary fibrosis, one thing I would like to add is here the question will ask what happens to the different pneumocytes. So remember, type 1 dies and type 2 proliferates in idiopathic. So how to remember? I die, that is 1 die, 2 proliferate. Okay, so that is how you remember idiopathic pulmonary fibrosis. So it will be repeated cell cycle of lung injury and wound healing with increased collagen deposition that will lead to the formation of honeycomb, right, appearance. So you can see red arrow in A shows the honeycomb appearance over here. You see, this is the honeycomb appearance, just like honeycombing. Okay, if you see honeycomb, they looks like this. So this is honeycombing in the idiopathic pulmonary fibrosis. Traction bronchiectasis can also occur because of the fibrous things can dilate the bronchi and may also lead to the digital clubbing. So Goodpasture syndrome, granulomatous and polyangiitis is another cause, and pulmonary Langerhans cell histiocytosis, eosinophilic granuloma, hypersensitivity pneumonitis, drug toxicity, for example bleomycin, busulfan, amiodarone, and methotrexate. Hypersensitivity pneumonitis can be both mixed type 3 and 4 hypersensitivity reaction to environmental antigen, causes dyspnea, cough, chest tightness, headache, often seen in farmers and those exposed to birds, reversible in early stages, okay, if stimulus is avoided. Unlike asthma, a hypersensitivity pneumonitis shows inflammation centered in the alveoli rather than the bronchi. Okay, so this is the very important thing. In asthma, the inflammation will be in the bronchi, but in hypersensitivity pneumonitis, the inflammation will be in the alveoli. Okay, remember this. This is very, very, very important. So this is bronchi. All right, this will occur in the asthma, and alveoli will occur in the hypersensitivity pneumonitis. IgG antibody type 3 and CD8 type 4 hypersensitivity reaction. Okay, so this antibody immunoglobulin complex will form type 3, and CD8 type 4 is CD8 T cells are responsible for type 4 hypersensitivity reaction. Okay, so here I have added that, baseline what happens in oxygen induced hypercapnia, okay, in COPD. So basically, uh, baseline hypo in what happens in the baseline hypoxia, there will be pulmonary vasoconstriction, high hemoglobin affinity for carbon dioxide, okay, and peripheral chemoreceptor stimulation will be there, right? So after oxygen administration, what happens? There will be vasodilation, diverts blood from well ventilated region to the non-ventilated region, okay? So there will be physiological dead space. So there will be VQ mismatch, remember that, okay? And decrease hemoglobin affinity for carbon dioxide, that is due to Haldane effect again. That will also lead to the increase partial pressure of carbon dioxide. And peripheral chemoreceptor stimulation will lead to decreased chemoreceptor stimulation, and there will be decreased minute ventilation. All of these will lead to the carbon dioxide retention. But if they tell you to choose one among all these, then remember VQ mismatch is the most important, okay? Okay, now I'm going to read what's written here. Patient started on high flow oxygen supplementation. Shortly after, she becomes increasingly lethargic and confused, okay? So this is because of the VQ mismatch, okay? Now, work done against elastic resistance is increased when tidal volume increased, while the work done against airflow resistance is increased when the breathing frequency is increased. So for a patient with stiff lung, that is increase in elastic resistance, the work is minimized when tidal volume is low and respiratory rate is high. For example, fibrosis and pulmonary edema or ARDS. So how to remember this? I will make a very simple thing for you, okay? So just remember, fibrosis, you have to increase the frequency. F for fibrosis and F for frequency, okay? So decrease the work, you just increase the frequency of breathing, and that is absolutely opposite to COPDs, right? So in COPDs, asthma, COPD or emphysema, you will have to, yes, decrease the frequency, right? So there will be respiratory rate will be low to minimize the work, okay? Now, talking about the some interstitial, I said you that there is bronchoectasis. So how it happens? Lung disease causes progressive pulmonary fibrosis with thickening and stiffening of the pulmonary interstitium. This causes increased lung recoil as well as airway widening due to increased outward pulling, okay? So so airway widening occurs due to increased outward pulling, radial traction by surrounding fibrotic tissue. The resulting decrease in airflow resistance leads to supernormal expiratory flow rates higher than normal when corrected for lung volume. So additional PFT is TLC, vital capacity, inspiratory capacity, and functional residual capacity and residual volume. Now I want to add one thing, that in ankylosing spondylitis, lung compliance is normal, okay, and residual volume could be normal or increased, okay? Remember this. Now getting into the next page. So this is very important, highly easy but highly tested, okay, and very easy thing if you be focused on what I'm saying. So characterized by sarcoidosis. Whenever you see sarcoidosis, just imagine a African American female, right, okay, playing the soccer. So that will make you recall of the demography. So in sarcoidosis is characterized by immune mediated widespread non-caseating granuloma, elevated serum S and elevated CD4 over CD8 ratio in bronchoalveolar lavage, okay? And this is not true for the serum. In serum, CD4 count is decreased, while in bronchoalveolar lavage it is increased. Remember that is very important. More common in African American female, often asymptomatic. Now this is very important. Sarcoidosis can sometimes be asymptomatic except for the enlarged not sometime but often, except for the enlarged lymph nodes. So this is the take home message for the sarcoidosis, that there is enlarged hilar lymph nodes, uh, leading to bilateral adenopathy and coarse reticular opacities. CT of the chest better demonstrates the extensive hilar and mediastinal lymphadenopathy. Now, associated with there are some features that you need to remember, and just remember uglier. I don't know how this mnemonic works, but somehow it helps to remember. Okay, so B for Bell's palsy, and now uglier uveitis granuloma. Now again, granuloma is non-caseating type, remember that. Okay, containing two special things, that is Saumann bodies and asteroid bodies. Asteroid bodies are nothing but the stellate inclusion body with giant cells. Saumann bodies are laminated concretion of calcium and proteins. Okay, now uveitis granuloma, non-casein epithelioid containing macrophage, Saumann and asteroid bodies. Lupus pernio, skin lesion on face resembling lupus, and this interstitial fibrosis restrictive lung disease, erythema nodosum. Okay, remember erythema nodosum can also be here. Rheumatoid arthritis like arthropathy, hypercalcemia due to increased 1-alpha hydroxylase mediated vitamin K, vitamin D activation in macrophages, and a facial droop. Okay, this is very important for sarcoidosis. So all these features are important, and you need to remember one very, very, very important thing, that is the treatment is by steroids if symptomatic. Now talking about inhalational injury and sequelae. So complication of inhalation of noxious stimuli, example smoke caused by heat particulate for less than 1 micrometer in diameter, or irritants, example ammonia, leads to chemical tracheobronchitis, edema, pneumonia, ARDS. Many patients present secondary to burn. Carbon monoxide inhalation, cyanide poisoning or arsenic poisoning. So it could be anything. That's how I have pictured here. You see, it could be carbon monoxide, it could be cyanide, it could be arsenic, any of those, and see what features it can cause. You see, it is causing wide variety of pathology inside our body. You see, there is singed nasal hair, one thing, and you can see tracheobronchitis. That's why you see I have inflamed the trachea and bronchi. There could be edema, that dot thing is edema. There could be pneumonia, or there could be ARDS. Okay, so any of those things. Bronchoscopy will show severe edema, congestion, severe edema, congestion. You see in the picture, bronchoscopy, you can see severe edema and congestion, and soot deposition 18 hours after inhalational injury, and resolution occurs at 11 days after injury. Okay, now I have added here what are the risks of second-hand smoke exposure. Okay, so one thing, that the baby will be premature if the mom is exposed to second-hand smoke, low birth weight, or SIDS. Okay, sudden infant death syndrome. So basically I have written here up to half of all sudden infant death syndrome are due to tobacco exposure, likely from the impaired arousal and abnormal cardiovascular response to the toxic stimuli by the tobacco. Okay, so remember that. And middle ear disease can also occur because of otitis media, asthma, respiratory tract infection, leading to back bronchitis and pneumonia. Right, now let's talk about what happens in the neonatal oxygen therapy. As I said, neonatal oxygen therapy can lead to retinopathy of prematurity, temporary local hyperoxia, upregulation of pro-angiogenic factors such as vascular endothelial growth factor. Upon return to room air ventilation, there will be neovascularization and possible retinal detachment. Blindness may result. This is called retinopathy of prematurity. Okay. Now let's go to the next page. So this is pneumoconiosis, and dear friends, this is very, very important, but I will make it very easy for you. Okay, so if the location itself will be a very big hint. So remember only one thing, that is on the lower lobe is asbestosis. How to remember that? You see, base is always lower lobes. Okay, so now talking about the asbestosis is from roof. Was common in insulation but affect the base. Okay, silica and coal are off from the base but affect the roof of the upper lobes. Right, now asbestosis associated with shipbuilding. Okay, remember this, roofing, plumbing. So ivory white calcified supra diaphragmatic and pleural plaques are pathognomic for asbestosis. Okay, So remember this, this is just above the diaphragm. You will see the plaque, okay, just like this in the image. You see, this is diaphragmatic plaque, okay, this thing. Okay, so now and pleural plaque, or you can see the pleural plaque over here, uh, this one, okay, this red arrow thing, this is the pleural plaque, okay, here you see this thing. Anyways, are pathognomic for asbestosis, right? Risk of bronchogenic carcinoma is more than for the risk of mesothelioma. So be very careful while you are choosing this option. Increased risk of Kaplan syndrome. Now again, Kaplan syndrome is arthritis associated with pneumoconiosis. You can see over here. Here I have made a simple, memory hook. So here you can see Kaplan is arthritis and pneumoconiosis, right? So this is all that you need to know in the asbestosis. Okay, so apart from that, you should also remember that asbestosis affects the lower lobe, as I said you, S for base. And asbestosis ferruginous bodies are golden brown fusiform rods resembling dumbbells found in alveolar sputum sample visualized using Prussian blue stain. Okay, remember this, often obtained by bronchoalveolar lavage. Okay, so two things that you need to remember is fusiform rods, and obviously it is formed of iron, so Prussian blue is used. Okay, now talking about silicosis. Silicosis is berylliosis, I'm sorry, berylliosis associated with exposed to beryllium in the aerospace and manufacturing industries. Granulomatous, obviously non-caseating one, right, on histology, and therefore occasionally responsive to steroids. So it is just like, asbest sarcoidosis. Okay, berylliosis is just a small brother of sarcoidosis because it is also non-caseating granuloma and it is also responding to the steroid. It can increase the risk of cancer and cor pulmonale, affects the upper lobes. Now talking about the coal worker pneumoconiosis. Prolonged coal dust exposure, macrophage laden with the carbon, inflammation and fibrosis, also known as black lung disease, increases the risk of Kaplan syndrome. So it is very easy, you see, just remember the coal dust getting phagocytosed by the macrophage, which is laden with carbon and which later forms the inflammation and fibrosis. Affects the upper lobe. As usual, I said you that the only asbestosis is affecting the lower lobe, otherwise all other pneumoconiosis affects the upper lobe. Small rounded nodular opacity seen on imaging. Anthracosis, asymptomatic condition found in many urban dwellers exposed to sooty air. Okay, remember this. Now talking about silicosis associated with sandblasting, foundries, mines. Macrophages respond to silica and release fibrogenic factors leading to fibrosis. It is thought that silica may disrupt phagolysosome and impair macrophages, increasing susceptibility to TB, increases the risk of cancer, cor pulmonale and Kaplan syndrome. Remember that. Okay, so it can also lead to the Kaplan syndrome. And one very important point, it can increase the susceptibility to TB by disrupting the phagolysosome and impairing the macrophages. So basically it will not lead to the formation of phagolysosome and also will paralyze the macrophages, right? So affect the upper lobe again, because only the asbestosis is the one which affect the base, but otherwise all other pneumoconiosis can will affect the upper lobes generally, right? Egg cell calcification of the hilar lymph nodes on chest X-ray. The silly egg sandwich I found in mine. This is the mnemonic. I don't like this at all, trust me, but if it works for you, then it's fine. So now here I have written here that birefringent silica particles surrounded by fibrous tissue. So this is the biopsy finding. Birefringent silica particles, remember this is birefringent silica particles surrounded by fibrous tissue hold collagenous nodules surrounded by dust laden macrophages. So there will be hold collagenous nodules surrounded by the dust laden macrophages. Here also I have written one point that exposure to silica causes the production of H2O2 and other oxygen radicals and damage lung tissue. Alveolar macrophages lead to the formation of TNF, interleukin and LTB4, which leads to the egg cell calcification. Now here I have written one thing about silica. Silica impairs the macrophage effector arm of cell-mediated immunity, which is integral to the immune response against mycobacteria. So what will happen? There will be, as I said, macrophage phagolysosome disruption. Extracellular release of lysosome is thought to contribute to the alveolar and interstitial lung injury in the silicosis. Okay, so they might ask you, so what is causing the lung injury? So basically it is extracellular release of lysosome enzyme. Okay, that is causing the lung injury. This is very sneaky point that you need to remember. And prolonged exposure of macrophage to the silica particles also appear to increase macrophage apoptosis. Okay, so silica can also kill the macrophage. Earlier I said that silica can paralyze, and it can also lead to the apoptosis of the macrophage, right? So let's go to the next page. Now, talking about mesothelioma. When I say mesothelioma, one thing that should come in your mind is that smoking is not a risk factor. So whenever you are doing a question, they will typically tell you, trust me, that the person is a non-smoker. Okay, and they will tell you all the findings in the mesothelioma. Not all, but the one which they have not asked, they will hide that, and otherwise they will tell you that there is malignancy of pleura associated with, and this is associated with asbestosis. But be very careful, because asbestosis can lead to the bronchoalveolar carcinoma, and that is more common than the mesothelioma. Okay, so may result in hemorrhagic pleural effusion, that is exudative. Okay, remember that, hemorrhagic pleural effusion. And Samoma bodies can be seen on histology. Okay, mesothelioma is also one of the cause of Samoma bodies, apart from many other things. Okay, like meningioma, okay, cystadenocarcinoma, and if you remember, papillary carcinoma, okay, of the thyroid. All those have Samoma bodies, but also remember mesothelioma can also have Samoma bodies. Calretinine positive, and calretinine positive is in almost all mesothelioma, negative in most carcinoma. Smoking is not a risk factor. So how to remember? Cytokeratin, call at rati. Rati is for night in our language. So calretinine and cytokeratin. That's how I remember. And Samoma bodies for mesothelioma. Okay, anyways, so now we will start the acute respiratory distress syndrome. So when I say acute respiratory distress syndrome, I want to tell you one thing. Okay, in acute respiratory distress syndrome, remember there is normal PCWP. Okay, this is the most important thing that will help you to point towards this diagnosis. Okay, so what happens? There will be alveolar insult, leading to the release of pro-inflammatory cytokines, neutrophil recruitment, activation and release of toxic mediators, for example, reactive oxygen species, proteases, and this will lead to the capillary endothelial damage and increased permeability, okay, leading to the leakage of protein-rich fluid in the alveoli. Now just imagine, okay, if there is any sort of insult, I will tell you what are those insults. It could be trauma, it could be pancreatitis, it could be pneumonia, it could be aspiration, it could be sepsis, anything, but most common is the sepsis. Classical case will be a person having UTI, protracted UTI, not treated by the antibiotics, and they are developing, sign of respiratory failure. Okay. So what happens? First of all, your alveoli is exposed to the insult, any sort of insult that I just mentioned, and there is release of pro-inflammatory cytokines, which will lead to the neutrophil recruitment, activation and release of toxic mediators, for example, reactive oxygen species, proteases, etc. Capillary endothelial damage and increased vessel permeability will lead to the leakage of protein-rich fluid into the alveoli, formation of intra-alveolar hyaline membrane, and non-cardiogenic pulmonary edema, normal PCWP. Diffuse alveolar damage is repaired by type 2 pneumocytes and infiltration of fibroblast, progressive interstitial fibrosis and restrictive lung disease. Okay, remember this. Sepsis is the most common. Aspiration, pneumonia, trauma and pancreatitis are other causes. Diagnosis of exclusion with the following criteria: abnormal chest x-ray, there will be bilateral lung opacities, respiratory failure within 1 week of alveolar insult, and decreased PaO2 over FiO2 ratio, that is less than 300. Hypoxemia due to increased intrapulmonary shunting and diffusion abnormalities. Symptoms of respiratory failure are not due to heart failure or overload. This is very, very important, because in question they will clearly mention you that PCWP remains constant. Okay, so this is one very important point that you need to remember. Apart from that, there will be bilateral lung opacities, as I said, and respiratory failure within 1 week of alveolar insult. That could be of any type. And there is decreased, partial pressure of oxygen in the artery compared to the inhaled fraction, right? And that would be significantly low, okay? That is less than 300. That is also a very important point that you need to memorize, okay? And obviously there is shunting, because there is, it's kind of blood not getting oxygen and getting shunted from the right side of the heart to the left side of heart without picking up the oxygen. So that is a kind of shunting, as I said you earlier. Now, symptom of respiratory failure are not due to heart failure and fluid overload. I should repeat it because it is very important. And consequences: impaired cash exchange, decreased lung compliance, and pulmonary hypertension. Treatment is by treating the underlying cause, mechanical ventilation, and decreasing the tidal volume, and increasing the PEEP, okay? Because mechanical ventilation will decrease the tidal volume, but increase the PEEP, okay? Remember that. So here I have written something about mesothelioma. Mesothelioma is a non-smoking patient. There will be a classic history of non-smoking patient with dyspnea, cough, and weight loss, has pleural thickening on imaging. So when you see there is non-smoking and there is pleural thickening, okay, then think of mesothelioma. What will happen is that there will be encasement of lungs in a rind-like mass, calcified mass. Histology: you will find a cuboidal or flattened cells, epithelial-like, or spindle cells, stromal-like. Immunohistochemistry is an important diagnostic. Nearly all cases of mesothelioma will stain positive for cytokeratin, as I said you, and may also typically stain positive for calretinin. So just remember two words: cytokeratin, okay, and calretinin, and you are good to go. Otherwise, there is cuboidal or flattened cells with spindle cell, and never forget about the Samoa bodies, right? Now, electron microscopy usually show polygonal tumor cells with numerous long, slender microvilli, abundant tonofilaments. Now, history of UTI. So as I said you, there will be history of UTI, sepsis, and ARDS. And now I will typically tell you shortly, in a very simple way, how to remember the three phases of ARDS. There is one thing, there is exudative phase, second there is proliferative phase, and last is the fibrotic phase. So each have the 1 week period, okay? So 1 week, what you will see: inflammatory cytokines, TNF, interleukin 1, interleukin 6 activate the pulmonary endothelium and recruit neutrophil to the lung tissue, which releases inflammatory mediators, okay, resulting in the endothelial damage, increased capillary permeability, and leakage of protein-rich fluid into the alveolar space. Organization of edema and cellular debris leads to the formation of hyaline membrane. Remember that, okay? So first of all, there will be, as I said, there will be permeability will increase and neutrophils will arrive there, okay? So just remember neutrophil and protein-rich fluid coming to the alveoli, so and forming the hyaline membrane. So there is exudative phase at that time. And in the proliferative phase, my dear friends, there will be full house invasion. You see, endothelial cells, okay, pneumocytes, fibroblast, everything will proliferate in attempt to repair the damaged lung, okay? So could be endothelial cells, pneumocytes, and fibroblast, all the components. See, one component from the blood vessel, one component from the alveoli, one component from the interstitial, okay? So all these will proliferate in attempt to repair the damaged lung. Collagen is deposited and scarring may occur. Edema is resorbed, okay? So there will be a resorption of edema. Now talking about the fibrotic phase, in a minority of patients, excessive collagen deposition leads to the irreversible pulmonary fibrosis and pulmonary hypertension. In a minority of patients, you can see there is excessive collagen deposition and leads to the irreversible pulmonary fibrosis and pulmonary edema, okay? Now let's go to the next page. Now this is about the sleep apnea, right? So sleep apnea, just remember there is repeated cessation of breathing, okay, more than 10 seconds during the sleep. That is why there is disrupted sleep in the daytime somnolence, okay? So as I said you, in sleep apnea, just imagine if you are not able to sleep in night properly, as you have a repeated cessation of breathing, so what will happen in the daytime? You will try to compensate your sleep. by daytime sleepiness. Diagnosis is confirmed by the sleep study. Okay, normal PaO2 during the day, nocturnal hypoxia, systemic or pulmonary hypertension both can occur, and arrhythmia is due to atrial fibrillation or flutter. There could be sudden death. Okay, so if there is sudden death in sleep apnea, think of arrhythmia, particularly atrial fibrillation or flutter. Hypoxia can lead to increased EPO synthesis and leading to erythropoiesis. Okay, now let's talk about obstructive sleep apnea. This is respiratory effort against airway obstruction associated with obesity, loud snoring, daytime sleepiness caused by excessive pharyngeal tissue in adults, whereas adenotonsillar hypertrophy in the children. And treatment is weight loss, obviously, because the obesity was causing it, and CPAP and surgery. Okay, so whatever thing that is obstructing the airway should be excised out. Now talking about central sleep apnea, impaired respiratory effort due to CNS injury, toxicity, heart failure, and opioids. So anything uh, causing the decrease in respiratory drive. So could be CNS toxicity or injury, heart failure, or opioids may be associated with Chine-Stokes breathing, and that I talked about in physiology, right? There is hyperventilation followed by apnea, right? So between apnea and hyperapnea, there is oscillation. Think of three C's: congestive heart failure, Chine-Stokes breathing, and CNS toxicity. Treatment is by positive airway pressure. Now, obesity hyperventilation syndrome, my friend, this is very important. Why? Because you should be able to differentiate it with the sleep apnea. Why? Because here you will find that increase in PaCO2 during waking hours. Okay, obesity leads to the hyperventilation, and there is increased PaCO2 during waking hours compared with the sleep apnea where ABG was normal, right? So here it is unique in obesity hyperventilation syndrome because it is widespread manifestation in accordance with time. It is also in the day, it is also in the night. So basically there will be increase in PaCO2 by carbon dioxide retention and decrease in PaO2 because of poor oxygenation. So also known as Pickwickian syndrome, but there is normal AA gradient, that is 5 to 15 mmHg. Clinical feature: chronic fatigue, dyspnea, and difficulty concentrating. Okay, so there will be chronic fatigue, dyspnea, and difficulty concentrating in this. Now talking about the pulmonary hypertension. Remember, pulmonary hypertension, normal mean pulmonary arterial pressure is 10 to 14 mm of Hg. So when it exceeds 25 mm of Hg, then it is pulmonary hypertension. Results in arteriosclerosis, medial hypertrophy. Okay, see the medial hypertrophy, and intimal fibrosis. Very important. So there will be medial hypertrophy and intimal fibrosis of the pulmonary arteries, and there will be plexiform lesion. Course is severe respiratory distress, cyanosis, and right ventricular RVH. Death from decompensated or cor pulmonale. Associated with loud P2, look for accentuated or loud second heart sound. Okay. Now talking about pulmonary arterial hypertension, often idiopathic. Okay. Heritable PAH can be due to